Hello and welcome everyone for tonight's EAO Just Ask. Tonight it's an enormous pleasure, and tonight we have to talk fast and be quick because we have such an expert and he had so much knowledge. We have so much content prepared today for you. We have Professor Markus Blatz here. He's a German. He is since more than 20 years, I guess. Markus, correct me if I'm wrong, in US. We actually share a little bit the same academic development in Germany. That's probably why I have a little less hair than you, because I shared this a little longer. Markus, it is an enormous pleasure to host you here because the EAO was very proud to have you here. So I really don't need to introduce you. You have one of the biggest Instagram account on earth, I would say, now in dentistry. You're a professor of restorative dentistry of the UPenn. You're a chairman of the Department of Preventive and Restorative Science. You're an assistant dean for digital and professional innovation. You have written so many books, bestseller books with Inaki Gamborena. You just told me you will write another probably bestseller book. You speak on all the big podiums, and we have an amazing topic. With this, Markus, a very warm welcome from Europe, a very warm welcome from the European Association of Osseointegration. Markus, it's a pleasure to host this with you.
Well, the pleasure is just on me. Well, Stefan, thank you so much for the opportunity, of course, to share some of the information. Some of that may, of course, be known as everything new is just forgotten old, I say. Yeah. But thank you so much for the opportunity to talk about it. Because, you know, what bothers me the most, and just for everyone who knows, yes, I started, of course, on Instagram a few years ago, but not to become influencer or whatever, just because really out of frustration. Frustration about the misinformation that I see on social media. That's good stuff, don't get me wrong. Great stuff, very inspirational, but also there's a lot of misinformation. And what really bothers you, to tell you the truth, is, you know, we as dentists, we as practitioners, we have a privilege, a true privilege to treat patients. With that comes some responsibility. And what really bothers me, if I see stuff that's not true, and then people say, oh, I believe that, or I don't believe this, and they talk about beliefs, which, I mean, that's okay if you're a spiritual person, that's fine, and of course then we talk about beliefs, but in dentistry, beliefs have no place. We should try to find out the truth, the answers through research, and that's why I want to, you know, you told me the focus should be Zirconia. And by the way, it's not that I'm in love with the material. It's just that I have researched that material for the last 26 years when I moved to the US, and really had a strong focus on that and see how it works and cannot work. That's why allow me, Stefan, to just give some.
Markus, just one more quick thing. Yes. I think this is what we want to do tonight. We want to bust some of these myths which we see all around, not only on social media, but also sometimes on the congresses. And everyone who listens, plus just type in your question. We will be more than happy to answer all of your questions. Markus is the true expert, and I also allow me as a surgeon to interrupt you at any point and to ask a stupid question of a surgeon. I hope you don't mind.
There's no stupid. And by the way, you may not know this, but I actually started out doing mostly surgery, by the way.
Right.
But then I moved more into the prosthodontics materials world. And so what I see sometimes, Stefan, it's just that misinformation. And I mean, I talk a lot about it because I hear it every single time I post on it. Somebody's, oh, I don't believe you. I don't believe that, zirconia is a ceramic and zirconia is a metal, because when you look at the chemistry of it, there's zirconia right now. And I have to go, man, I'm sorry. You have to understand, the key thing for us to make the right decisions about material is we have to have a fundamental understanding. And that's what I'm trying to do. That's why many of my talks are, people say, oh, it's very fundamental. That's exactly what I want to do. Because That's the only way for us to make the real decisions. I want people to make their own decisions, not believing in any group or this group or that group. They pray something and then everybody has to say, do the same thing that the guru does. That's not dentistry. We are smarter than that. And this is why, just those basic stuff, again, every single time I talk about zirconia, somebody says, oh, zirconia is a metal. I said, well, zirconium is a metal element, that's true, but we're using in dentistry zirconium dioxide, which is inorganic, non-metallic, crystalline solid. This is the proper term for it actually, but we don't have to go into details here. But what I try to make people understand, if you talk about metals versus ceramics, first of all, what are metal properties? Gray, metallic bonds, ductile wear, thermal conductor, electric conductor, easy oxidation, magnetic, all this stuff is metal properties, right? When you look at zirconium dioxide, as we use in dentistry, it's the total opposite. It's white, covalent bonds, hard, and brittle. And that's the key to have to understand when we select a certain material. What are the properties and how are we using it? It's used as an insulator. It's used for thermal insulator and electric insulator. It's non-magnetic. It does not corrode. It has this oxide part in it, which also we'll talk about in a moment, helps with biologic integration. But anyways, why do I care so much about it? And what really startles me all the time when people say, well, but, zirconia is a metal, well, when you look at lithium disilicate, I ask you, what is lithium? It's a metal. Does that make lithium disilicate a metal? No. Most veneering porcelains have metal oxides in them. Even enamel contains calcium, which is actually a metal. So just because there may be metal elements in them, or maybe again, the oxidate part of it, the particle of it, that does not make them metals. And why is this so important? Because if we don't understand this, we make the wrong decisions. Metal alloys have the ability to undergo plastic deformation, ceramics do not. They are brittle materials and they break easily. Look at this. This is how we test material, flexural strength, zirconia versus a metal. And you see, same force applied. Metal alloys can deform themselves, zirconia cannot. Why am I telling you this? Because when we see stuff like this, we oftentimes blame the material. Oh, zirconia doesn't work, it breaks. We didn't use it the right way. We didn't understand the material. It's not the material's fault. Either, we didn't follow the proper dimensions, or, we didn't have a proper impression, things like that. And this is why not everything has to be done with zirconia. Not everything has to be done with one material. We're too smart for that. Based on the patient's indications, based on the patient's situation, we can choose all the materials that we have. Different types of ceramics, metal alloys, based on the indications. And I don't understand why we always try to push for this one material that can do everything. There is no such thing. And I don't think there should be, because there's different requirements that we have from both an aesthetic and also a functional standpoint. And
we'll learn about this. Can I ask you one question?
Sure.
Does that mean maybe the old gold inlay isn't completely gone for you in restorative dentistry?
Only due to cost reasons. Other than that, I think it's a beautiful, beautiful material.
I get your point. I took over the office of my father and he did, I think for 40 years, he did gold inlays, and I still look at them and they look fabulous. And the patients are very satisfied because of the biting luxus that they feel.
Exactly. That's why, no, I don't dismiss any material. And that's, I think, is where we sometimes are ill-advised. Not everything has to be zirconia. Not everything has to be printed nowadays. Not everything. We are too smart for that. And I think we have to make our decisions based on the patient. And also, as I just mentioned, based on the science. And you know what? Those partial coverage gold restorations, they have really great long-term success rates.
Got it.
And the same applies also now when we talk about zirconia implants. Why do they have to be different from a titanium implant? Because it's a different material. It's much more brittle. It has a different electric load. So yes, these are the things that we have to understand basically with that. Let me just dive for a minute, since you told me to go quickly into this deep dive here, into also for us to understand that zirconia is not an easy or simple material. And we learned that the hard way, especially in the beginning. And we also know that not every zirconia is the same. So when you have problems with your zirconia that comes from your lab, fit or fracture or whatever, talk to them and find out what they're using and how they're using it. Again, the most discriminating factor when it comes to success and failure is usually us or the dental technician not understanding the material properly. And that's what happened in the beginning. When you're using, for example, we're using these blocks to mill from zirconia typically. We can also print zirconia, of course. But right now, the predominant way is to mill it. And those blocks that we mill from, when they have areas that are not homogeneous enough, you don't have the full strength in all those areas. And this is why manufacturers have started to make sure that we have those high density blocks available that we mill from, and to get rid of some of these impurities. Also, we all know we have the 3, 4, 5 wire zirconia. I don't have to go into the topic here. They have different particle grain size, which also influences their properties physically and also, of course, from an optical standpoint, besides the fact that we have, of course, more cubic particles in the 4 and 5 wire zirconia. But just little changes in temperature, sintering, for example, will give you a different material, because the particle, this particle growth is very different based on the temperature. So just the fact, if the dental laboratory does not calibrate their furnaces properly, you get a totally different material that does not have exactly what you expect from a optical and flexure strength standpoint. And so they're not all the same. But what we also learned in the past was how do we use it in clinics? As you all aware of, in the early days, zirconia, because we only had the white zirconia available, was used mostly as a coping or framework material. And this is when we went wrong, when we then selected the veneering portions for that were originally based on metal alloys, right? Only over time we understood that we have to use a very different veneering portion for zirconia based on its thermal and physical properties. So yes, we can achieve results like that, but have to understand that without the proper veneering portions, in the beginning, we saw a lot of chipping. We didn't understand it properly. Use the same veneering portions that we used for metal alloys and hope that it would work, which of course did not make any sense at all. Of course, in the meantime, we all know that we have proper veneering porcelains that are adapted from their coefficient of thermal expansion to the zirconia framework and then give us great success. While we were in the developmental and research stage of those, still many people said, well, you know what, all the chippings, and it's such a big problem and cannot be solved by just changing the veneering porcelains, but it did. We also had a number of clinical studies that we did, and I just want to share with you here a 7-point-something year follow-up when we compared posterior porcelain fused to zirconia restorations, crowns, all crowns, over 1,000 that were made in the practice. The crowns were made from one dental laboratory with expertise in this area and also using the proper veneering porcelain. And to have a comparison, we compared them to porcelain fused to metal restorations, right? Following them up for a number of years. And with this now better understanding of the material, actually chipping rates were exactly the same for porcelain fused to metal as for porcelain fused to zirconia restorations. And now we're looking at even like 16-year data. We have about 7,000 restorations to look into, and found pretty much the same success rates. And
Markus, let me interrupt you for a second, because this is so interesting. Remember, we also have sort of like beginners in the audience. Anyway, we see in the big systematic reviews and meta-analysis that chipping is by far more evident than you showed it in your study here. Let me understand that. Is that because of the manufacturing of the layering, sort of the quality of how this layering is done? Or what do you think? Where is the reason for these differences when we compare it to daily practice and also the reviews we see?
So interestingly, these studies were actually done in the practice. This is not a university-based study. We're done in the practices. But, you know, we have to differentiate, of course. These were single crowns. When we talk about full mouth reconstructions, for example, it's a little bit different picture. One of the problems with zirconia is, as a thermal insulator, that it will contract heat. You know, so We also learned that the cooling process plays a very big role. So we have to cool it down much more slowly than when you have, for example, a metal framework. And of course, a full mouth reconstruction is a little different story. So here,
But again, let me
yeah,
just cling into that because it's so interesting. Me as a beginner, how can I control that? I mean, you know, it's difficult. How can I control my lab technician with the cooling process? I mean, what would you advise me?
follow manufacturer's instructions.
Yeah, yeah, I got
That's
it.
always the key. But also, I mean, no, for full mouth, of course, the nice thing about zirconia is also we don't have to do full veneering.
Yeah,
Right? We can do partial veneers, and that's
yeah,
why if you ask me for full mouth reconstructions, which we can of course discuss as long as you want to, but typically, you know, many dental technicians they only do a micro layer or mini layer on the anterior part of it,
yeah.
just to make it a little bit more aesthetic. But everything else can be in zirconia, because what we also learn is that the zirconia framework should be more supportive than what we could do with metal frameworks in order to prevent any chippings, especially in those larger reconstructions. This
Okay.
was just an example for those, single unit crowns, which is a little different story. You don't see as much of a problems, but for the full mouth reconstruction, but even there, especially when we use these micro layering protocols and have most of the chewing forces going onto zirconia, and I show you something in a moment, what this should look like, these problems are minimized.
Got it. Great news, Markus.
I mean, of course, when we talk about and go back to this, we tried different veneering materials as well. We ran a 5-year study on the system. It's called CAD-ON, where you actually have a lithium silicate CAD-CAM fabricated veneer that you fuse onto a CAD-CAM fabricated zirconia framework, and they work actually very well. But I would say with those new monolithic zirconias available now, it's not as important anymore. But the difficulty, of course, with the newer, more translucent zirconia versions is now the dental technician has to fabricate a tooth-looking restoration, not by building it up as they used to do with our layered, of course, restorations. Now they have to give also illusions by using certain colorants,
Yeah.
and so it's much more difficult. And also for the dentist, because if your shade taking is off, a good dental technician by layering, they could always modify the shade to a certain degree. Of course, when you have a full mouth reconstruction, that's out of the question anyway. But shade taking is key, of course. And we just published a paper on that, trying to help our colleagues to how to take a proper shade to be more on target. We can always make things a little bit darker, but making it lighter is very difficult with those monolithic restorations. But it gives us a different option when it comes to, of course, strength, because now this whole discussion about layering porcelain is out because you don't need it anymore. And we can get impressive results if we understand how to do this properly. And again, it all depends on also the laboratory and the collaboration, of course, with your laboratory to get these results. We're also looking at multi-translucent materials. As you all know, we have them available. I have a clinical study in progress right now. Understanding, though, that another discussion point that we always had was wear, right? And people say, oh, it's zirconia, wear so much because it's a hard material. Yeah. And I would say, well, hardness does not create wear. Roughness creates wear. Rough zirconia creates a lot of wear. Non-rough zirconia creates very little wear. As a matter of fact, enamel causes more wear on enamel than zirconia causes on enamel, quite interestingly. And also, many of the silica-based ceramics, feldspathic porcelain, lithium disilicate, they actually, because of their large crystals, they actually cause much more wear than zirconia does. And another thing that's important, and most of you know that, of course, is that glazed zirconia causes more wear than polished zirconia. This is why the occlusal surfaces, we really try to keep polished. You can see here after wear, for example, you can see how some of these glazes are chewing off over time, because also one of the problems that we have is that those glazes don't adhere so well to zirconia. So when they're worn off, they cause small wear than if you just polish it. That's why, typically what we recommend to do is, to polish them. There's specific polishing systems, 3-step or 2-step systems, which are really, really good. That can help us prevent it from happening.
Markus, let
Another
us
thing is,
digest that
yes,
for a second because this is so interesting. This is probably one of the biggest myths which is going all around the world on every congress. Let us digest that a little bit more also for the beginners listening to us, or also for the real professionals. You're saying that if a zirconia is perfectly polished and is maybe not glazed, there's not much more wear than natural enamel, correct? Enamel.
yes,
Wow. Wow. It all depends on polishability and avoid glaze in functional zones, correct?
exactly. But not only
Perfect.
that, I show you something what we do right now because so when we have a restoration crown, let's start with the small stuff first. We talk about crowns right now. Actually, what I do nowadays, what we do nowadays is actually we mark the margins and then we take the glaze off also of those marginal areas. Don't do this at home. You have to be really careful. You don't have to destroy those margins. But why are we doing this? And we can talk about this more if you want to. Soft tissue adherence. We
Sure.
know there is the inner epithelium cell layer, and this picture is from Peter Schuppach from our book with Iñaki Gamborena on anterior single implants, anterior implants. And we know we get better soft tissue adherence as well, which is another point.
Are you doing that only in subgingival prepped crowns
Yes.
or anywhere?
Again, only subgingival areas.
Got
Yes,
it.
of course.
Got it.
Absolutely that. And then we know that for full contour restorations, crowns, whatever, or even if you implant and you may have single crowns, bonded to your or applied to your framework, for example. If you have good retention, you don't have to bond any of your zirconia crowns. That's not necessary. That said, do you want me to go into maybe some alternatives to the implants? Because we
Yes,
know we
go,
don't,
go, go, go. We have all
because
the
we
time.
understand that
It's
we
so
that we
interesting.
cannot bond or don't have to bond these crowns, but we talked a lot about, and many people do, about resin-bonded bridges. The advantage of using zirconia here is, of course, its color, and you can make it very thin. And this is why we've done this for so many years. And specifically, yeah, we are proud of the cases that we did, and we look at the pictures a year, 5 years later, and it's all great. I see some of my cases now in 15, 20, 25 years and beyond sometimes, and you learn. That's how you learn. Look at your cases, look at your colleagues' cases, and don't just blindly follow what some people tell you. And we've seen, you probably have the same, that we placed implants several times, unfortunately, in patients that were too young for that, right? And so we have seen movement of upper anterior teeth, and what once was a very nice aesthetic situation, 5, 10, 15 years down the road, when the patient is still young, everything is a mess. The
That's
teeth
why
are
I
big,
several
it
times
stays.
changed the location of my office, Markus. No, I'm kidding.
No, our mantra, my mantra has, the more full mouth reconstruction, I'm a trained prosthodontist, the more I do the big cases, the more I'm trying to avoid them, right?
I agree.
To try to be less invasive and
Yeah.
find tools that I can use to be less invasive to
That's where
prevent.
the periodontist also comes into play. Save the teeth.
You don't want to comment on that because
Yeah.
yes, unfortunately, we have, and I can say it because I had this dual training in
Yeah,
Freiburg,
I know, I know.
with the perio and pros, and yeah, I just see, and there's just implants sometimes placed too early and
Yeah,
too many of them as well, and
good point.
that's when I scratch myself sometimes and say, man, maybe I shouldn't have done this. But what are the alternatives?
Yeah.
Especially in young patients, why we talk a lot about, these resin-bonded bridges. We know, and that's another thing. Oh, I don't believe in zirconia bonding. People don't believe in zirconia bonding. That is something that, I'm sorry to say, drives me crazy. Why? I've researched that for over 26 years, thousands of specimens, hundreds of publications. I've seen it myself, and then people come to me, oh, I don't believe you, I don't believe. It's not about belief, and then we have clinical studies that show that, and we know that we have to have the understanding. Of course, it doesn't work if you don't know how to do it. Oh, I don't know how to do it. So how do you expect it to work? It's very simple. Anyways, I mean, there's a few things you need to understand. And one thing is one retainer only. I know we always try to have this conventional or traditional Maryland bridge design with two wings, makes us feel better. Doesn't make any sense when you have a brittle material in between two mobile elements, something will give. And as we've seen, that's usually one of the connectors. And that's when we started with just one retainer ring. Boom, there you go. And now we see more and more systematic reviews and analyses that support that as well, because it's not just us, it's many groups around the world who understand that much better. And again, no debonding in many of these studies that we see, or very little debonding actually. And again, this is something I've researched for 26 years, and it's sometimes quite frustrating that I'm still getting the same head shakes when I say, yeah, we can bond zirconia. They're like, I don't believe it. Okay. What do? You all know it. We clean the restoration after try-in, air particle abrasion with alumina. It does not destroy the surface. Don't worry about it. Just do it shortly. Special primer, and then after applying the special primer, we can then use, of course, composite resin cement. I called it APC technique a couple of years ago, just to maybe stick it in people's heads a little bit easier, more easily. But again, just call it air abrasion primer and composite APC. Again, I don't care what you call it, to be honest. Just do it. and that pretty much solved the problems. And here, a case in Tony Rotondo, that we published very recently, just to show you the possibilities also from a soft tissue standpoint, because it's always said, oh yeah, it doesn't look so nice and soft tissue and all that. Well, it depends how much effort you put in there. And what was done here, after of course tooth was removed, connective tissue grafts replaced, you can just, as you manipulate the soft tissue around your implants, you could do it about those fixed restorations as well. Problem always was that with our ponic design for our anterior bridges, we always push the tissue towards the palatal and not towards the front. That's why this was really nicely done here, when you then add successively acrylic or whatever material you're using with this removable device to push the tissue forward and not the opposite direction. And with that, creating these soft tissue housings, even for resin-bonded bridges, to then have a result that's pretty decent, So thanks, Tony, for that, helping
Beautiful
with this
case,
technique.
Markus. Beautiful case.
And so that was the goal here. And the great thing about this is you can always place an implant later.
Yeah.
That's the nice thing. So people don't understand. Everybody wants to make the quick money and the quick thing right now. You can always place the implant later. There's many cases that you'll have where you can place the implants right now. Buy some time.
And you already improved the soft tissue condition.
Exactly. And you can, of course, there may be the exception when you see very rapid bone loss. You may say, maybe I place it earlier. But typically, we don't place implants anymore until late 20s in those patients, in young patients. And we can buy some time. Not in everyone. Right. That's why everyone's listening. Talk to your surgeon about it and find out when the right time is. But later is better than earlier, just as a general rule, right?
Right.
And we can see now, this was a very nice study. Unfortunately, as you all know, Matthias Kern passed away last year, right around the time when this incredible study came out, where they looked at 15-year survival rate. I mean, we have a survival rate of 100% in the lower, 90% for lateral incisors in the upper, 90% for upper central incisors with resin-bonded zirconia bridges. And then people still tell me you cannot bond zirconia. I don't understand. I don't understand. I really don't, But anyways, the thing is that it's in people's head, and then they tell me, oh, why don't you use lithium silicates, easier to bond to? Okay, let me just real quick. Stefan, you allow me to just explain one concept?
Sure.
About bonding to ceramics in general? Because people also focused on the ceramic part, and they don't focus on the tooth part, but we have two bonding interfaces, one to the tooth, one to the ceramic. Now, as long as the one to the ceramic is as good as the one to the tooth, we're in good shape. And it doesn't matter if the bond to the ceramic, even it may be better with lithium silicate, but it doesn't really matter as long as it's as good as the one to the tooth. And then people don't focus on that. Do you use rubber dam? Oh no, your bond strength to enamel goes down by half if you don't use rubber dam, just by humidity from exhaling and inhaling, by the way. And then you have maybe 15 megapascal or something, and then we easily get that, and even much more when we bond properly to zirconia. Yeah. But do you do it properly? It's really key, and it can work. Then people come up with all different things now, using certain acid edges or using certain, silica coating, which when you look at long-term studies, and all our laboratory studies are also undergo a artificial aging process. Right now, what I just showed you, APC, still seems to be the best way to go, especially when you apply these tools to it.
Got it.
When we go into the implant part, of course, just really quick, another nice thing about zirconia, again, I'm not in love with zirconia. I'm just trying to say what's good and what's bad about it. Another thing that's good about it, bacteria does not like zirconia. Bacteria does not like zirconia. And you can see specifically when it's polished. Quite interestingly, though, that applies to almost all the materials that we have tested here, for example, that the polished surface did attract less bacteria than the glazed surfaces. Of course, when you have your composites and you composite some light cure glazes, they're not that great anyways. Makes a lot of sense. But even in your lithium silicates and other materials, we could see that you have much less bacterial adhesion when you polish those areas that may be prone to plaque accumulation much more and you don't really need it. Again, this is from our book from Peter Schubach about soft tissue integration to zirconia, and you can see very nicely that the inner epithelium cell layer can nicely adhere to the material, which of course people now do BOPT, vertical preparation designs and things like that. So you have larger areas that will come in contact with the soft tissue. So here it may be advantageous to not have a glaze. This picture I got from Eric Rompen from a zirconia abutment that was in place for about 6 months. And you could see very nicely the soft tissue adherence, which stopped at a certain part. And this was when there was a glaze. Again, this is why we decide always to have no glaze in those soft tissue bearing area. And if there is, which typically you would only do for aesthetic reasons, that the glaze is only there to put some colorants on it, but just remove it, and then you will get what you would expect for those specific restorations.
I mean, even what is the issue of a glaze in a subgingival area, right?
Again, exactly, you don't need it. But sometimes the technician may not think about that, and you look at it and go like, there's a little bit that went down if you have a full contour. When you have a zirconia abutment, you don't have to worry about it because I don't think anybody would put glaze on that.
Markus, I have one more question to this.
Sure.
I also see, or we see it in literature, that soft tissue loves zirconia. But my question would be to you, is that because of the material per se, or is that because of a better polishability when compared to other materials?
It's probably both. It's probably both. Polishability is certainly a factor, but similar to, what makes titanium so biocompatible?
The oxide layer?
Exactly. Zirconium dioxide. So there is a certain adherence also through that part. At least that's what we hypothesize. But so I think it's both. It's definitely both. But definitely also, of course, the inertness after you polish it to a high shine is certainly a key factor for sure. Yeah.
Gotcha.
Well, and then again, of course, we can, as we mentioned before, full mouth reconstructions, they can have a variety of different designs. You can use a more skeleton design. You can choose the micro veneering. That's something, of course, we always do, depending on what the patient needs are. And mainly also, what is the dental technician capable of? And you find very different. That's why it's always very important. Don't just ask for something, but discuss it with your dental technician and find out, what are they capable of. It's really different. What type of zirconia are they using? What are they comfortable with? It's really critical to do that. And this is why I think there was a question that was posed, what is my preference from an aesthetic and functional standpoint when it comes to full mouth reconstructions? And I said, I don't have a personal preference. Most of the time in the upper jaw, we will do full contour zirconia and just a micro veneer layer on the labial aspect. But again, it really depends on your dental technician and what system they are using, what veneering portions that are using, what they're comfortable with. This would typically be the goal for that in general.
Markus, there's a question from the audience, from Ali Salman. It's a little bit a broad question. I don't know how this is meant, but I will just shape it to what I think she thinks of. She asks, how do you see tissues creeping around zirconia? I mean, we talked about this, soft tissue loves it. We maybe see a creeping effect coronally. What can she do to sort of improve this effect? Polish it, or what could you recommend her?
Yeah, polishing. Yeah.
Yeah. So the biggest thing is high polishing, no glaze in that area. That's the backbone.
Yes, absolutely.
Good.
Asking more questions.
Yeah. Just ask questions. Okay, let's continue.
Do you have some questions for me now?
I think the other questions are a little bit more more generally. You want to hear one of these?
Yes, please.
So one question is, and I thought it's interesting, from Lucrecia. She's also part of the EAO, and hello to Lucrecia. She's asking about veneers. Should she use like monolithic zirconia veneers, or is that still an area where we should go for feldspathic or layered structures? What is your take?
My preference, and again, I'm trying to also use a variety of materials for different indications. Not everything has to be zirconia, not everything has to be lithium silicate, not everything has to be whatever. And my preferred material for veneers typically is lithium silicate or feldspathic ceramics, based on, again, also talking with a dental technician, or what is able with, if we use digital dentistry, of course. But what I showed you about bonding zirconia for those bridges, the same rules apply for veneers.
Yeah.
And it really depends on the substructure. If I have a very, very discolored tooth, and we know that due to the high translucency of those silica-based ceramics, which is great, which is, of course, an advantage of it, could be a disadvantage when you have a very discolored tooth, like tetracyclic stains, whatever.
Yeah.
This could be an indication for zirconia, absolutely. If you want to bring up the brightness and the value to a certain degree, that could be an option. And we have done a number of cases, actually, with zirconia veneers. If you understand how to bond them properly and you follow those protocols very closely, not a problem whatsoever.
Would you change your prep design when it comes to both of these materials, saying like zirconia versus feldspathic, like this palatal chamfer, you would do the same?
No palatal chamfer, first of all. And second, the key is to understand, for all those partial coverage preps, both anterior and posterior, is actually, we only create space for the ceramic. We only create space for the ceramic. Yeah. And so we have to follow manufacturer's instructions about how much space do they need. And also we have to make our preparation, of course, based on our digital or analog design, on our wax up. So if I want to make the tooth wider, larger, bigger, I may not have to prep anything at all, or very little, actually. That's difficult to make totally non-prep. It's always a little prep typically, but just to create space for the ceramic. So for me, there's not a difference what material I'm using, because you don't want to over prep. The only thing is, what's nice about for example, zirconia versus lithium silicate is specifically when we talk about those resin-bonded ridges. And before we had even zirconia available, I did tons of lithium disilicate resin-bonded bridges many years ago. And but you need more space. You need more space for the connector. You need more space for the retainer wing. And this is one of the limitations with the material. It's no problem to use it if you want to go for it, but you have to have a more invasive prep. And the danger specifically on the palatal is that then you may be ending up in the dentin, which is again the other bonding interface, which if you weaken that too much, this is where it will fracture, not on the ceramic. If you treat your ceramics properly, lithium silicate, zirconia, whatever, those bond strengths will be higher than the one to the tooth structure. Okay.
Perfect. Got it. Markus, you have some more content for us, or should we stick with the questions?
If you don't mind, I mean, you remember, I want to show you this.
Yeah, go for that. Come on.
I would like to. Okay.
Have another 10 minutes. Let's go.
You all know me talking about zirconia all the time, and it's not. I love this.
Let's go.
Of course, so many, but our research has also evolved, and the more I work in this field, the more I am also concerned about how can we prevent all this. The problem really is, I'm sorry to say that, but we get rewarded for being invasive. The more invasive we are, the more money we make. It has to be totally upside down. And I hope with all those things that we do these days that we can convince also insurance companies and providers that this has to be the way to go, because this will also ultimately save them a lot of money. Sure. Anyway, so I focus a lot more on how we can prevent these things from happening, how we can prevent periimplantitis, for example. And our enemy, as you all know, is actually biofilm. And biofilm is a very complex structure out of different bacteria, fungi, held together by so-called EDS matrix. It sticks to surfaces, implants, teeth, restorations, and it's very difficult to remove, actually, And yeah, we all know rinsing, things like that, has very little effect on it. By the way, there's also some cool tools that you can use. Some of the microscopes that are being developed right now have this available as well. That you have special filters, and you have a UV light where you can make bacteria actually visible. You can see, should you treat a caries or dark lesion on a tooth. And again, not as a trained prosthodontist, I had little understanding of cariology in the early stages, but I learned a lot about it in the meantime. Since we teach comprehensive dentistry in my department, it's all together pros and restorative. But first of all, seeing what we have there and seeing those bacteria is quite helpful for it to make it visible. One of our groups right now, and it's our Center for Innovation and Precision Dentistry at the University of Pennsylvania. We're working on a certain research project right now where we're using antimicrobial micro robots to remove biofilm. And again, biofilm is not just a problem in the oral cavity, as you all know. It's responsible for about 80% of all our ailments that we have in the general health. And it's quite interesting, in dentistry, some of these nano-robots or micro-robots are already used to transport medication in certain areas. We are developing systems right now and tools that can do that in the oral cavity. And the idea behind it is that you have certain iron oxide nanoparticles that are magnetic, so you can move them in a magnetic field wherever you want them to go, basically, in this magnetic field. And these nanoparticles are catalytic. They break down the EPS, and they also kill the bacteria. So what we're doing right now, using these particles to then, again, clean off any biofilm that may be there. So we can tell those particles, hey, you know what, like a cleaning crew, just remove the biofilm, kill the bacteria, and to really clean it properly, and not just superficially. And this is something that we're looking at right now, also in those nanotubes as well, to arrange these nanoparticles in a certain way and assemble them in a certain way that we can also go, for example, on tooth surfaces, having a device that you can put in the mouth, either the dentist and or the patient as well, and then having these little particles pretty much clean off teeth. And you can arrange them like tooth bristles. And the great thing is they're so small that you can go really in between teeth with them and you can even go below soft tissue. So hopefully, again, in the future, talking about perimplantitis treatment, we can then move those particles in 2 to 3 millimeters below the soft tissue margin, actually. Or, as you can see here, endodontics could be another area where these nanoparticles that eliminate and kill the biofilm in again, for example, in the cavity here, could be quite helpful. You have a couple of.
You think, Marcus, that could also be in the future something for the non-professional, like for home cleaning, or is that,
Absolutely, yes.
can we
That's
think of that?
That's of course the idea. But now we have a couple of animal studies going on right now for multiple indications. One of them is, again, how far along the implant will or can we guide those particles successfully. We also looking at various indications for those particles. They could also be used even for a rinsing solution. So without targeted effect, but for a rinsing solution. And by the way, those particles are actually FDA approved. It's actually something that's also being given for people with iron deficiencies. So it's not something totally crazy or not. So what we're trying to do right now is to have different applications for those nanoparticles. One, yes, as rinses and gels maybe, but even more so, of course, having a device that one in the practice you can use also for periodontitis treatment, and then also for patient where pretty much like a tray that they put in the mouth and then having the teeth cleaned professionally with those nanorobots.
Marcus, that sounds amazing. I think the future is in your hand a little bit, I feel. Wow, interesting. It could also be, as a periodontist, I'm also thinking about biofilm modulation. We're thinking about this, maybe just changing the microbiota from anaerobic bacteria to gram-positive bacteria. That could also be something like to shift bacteria, right?
That's, by the way, that's why you're so smart, Stefan, and I totally agree with you. And what we can do, the great thing about these, you can actually also dope them with other. You can dope them with certain fluorides, for example. And the cool thing is you can target the bacteria. I didn't bring the whole thing here, of course, but we have actually some studies going on right now, clinical studies even, where we can then use these particles to target certain bacteria types, that are more pathologic than others, because yes, you don't want to kill. I mean, bacteria is important, of course, but there are some good ones and some bad ones. And the cool thing about this is we can target the bad ones and leave the good ones in place.
Marcus, that was amazing. I mean, I loved it. Now a periodontist finally understood about ceramics. I just remember I took this big piece now, like enamel is pretty much the same, then polished zirconia. Stefan, understand it now. I got it now. Marcus, that was amazing. The people, they applaud you. All the listeners, they applaud you. I still have 2 or 3 questions left, which I would love to hand over to you. Amazing. Thank you very much. We're also on behalf of the EAO, I think we maybe see you at one of these annual congresses in the future. Let's don't say too much. But by the way, there is an annual congress this year in Lisbon. Marcus, maybe Lisbon in falls, not so bad. So there's already there's still a pre-registration rate. So make sure make advantage of this. Marcus, are you still there for 2 or 3 more questions?
Sure.
We need
I'm here for you.
to use your knowledge as much.
And you, I mean the audience. And you, of course.
Yeah. Marcus, there's, I think, one question. Alfonso Gil is also here. Hi, Alfonso. Thanks for listening. He has an interesting question, also looking into the future. First of all, what do you recommend us when like the manufacturer's recommendation of how to mill zirconia is so important? I mean, a little bit the same question what I had. How can I control that as a clinician? Because at the end of the day, I am, as clinician, I'm responsible.
Yeah. Controlling it, unfortunately, I don't know how you would control it, to be honest. I mean, just work with trustworthy sources and trustworthy dental technicians. And we always keep learning, actually. And the most important thing, I believe, is always, I mean, everything I'm telling you is not because I'm so smart or so great, it's because I had my failures. Everything I learned from failures. We learned all these things from our own failures. And that's the most important. You cannot prevent failures, but the key is, can you learn from them? Do you understand why it happened? This is why, like I said, I go so much into the basics again, because then you can understand. For example, when you see fractures in your FP1 restorations, okay? Full mouth implant, FP1, and what I see a lot of times when dental technicians think the traditional way, and then they kind of use the discs to separate the teeth nicely to look like separate teeth, right? And this is death verdict many times, because when you make also those interproximal areas, right, those embrasure spaces too sharp, these areas are prone to fracture very easily. And sometimes I see that from dental technicians after everything's done and they want to make it separate a little more. Boom, this is one thing that I've seen quite a bit in the recent past. And people say, oh, it's the zirconia's fault. No, it's not. So these things you may learn, unfortunately, from mistakes, trying to prevent them. That's why I talk so much about it.
Yeah.
And it's why you guys talk so much about it as well. But it's just, hey, being a team and understanding if something happens, why, and prevent it in the future.
Yeah.
Otherwise, you're going to make the same mistake over and over again.
Also, another question coming up, also looking a little bit into the future, will we see like printed zirconia in the future?
Absolutely, yes. I mean, we have done studies with that for quite some time. Unfortunately, right now, it depends on the system. It's
And
still,
would you expect them to have better properties?
at this point, not. I mean, one of the advantages again that we have is that we can make those blocks that we mill from super, super dense. And so, yeah, we have to see.
Okay.
But always another thing is though, strength is not everything. Everybody focuses so much on strength. Modulus of elasticity, how a material behaves under stress, is much more important than just pure strength. Everybody's stronger, 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 stronger. I don't know. I don't know.
Get your point. There's a little bit more broad question from Jose Alejandro. Maybe you answered it in a nutshell. It's very complex. He just wants you to tell us when he should go more for a complete monolithic material and when he should go for like a cutback technique or a microlayering or whatever. Just maybe 2 or 3 sentences. I know you can talk about this for 2 days.
Again, it really depends also on the collaboration with the dental technician. It's how honestly, that's how I do it. I talk to dental technicians and listen, how can we solve this case? Patient has these requests, this and this and this and that. Of course, we make our try-in restoration to see if we go in the right direction, and then we take it from there. And it's so different. Every patient's different. And what I've given up completely since I moved to the US 26 years ago is to tell patients what they should look like or what color their teeth should have. Forget about it. Why should I tell them? So we listen to the patient, what their needs are, how defined they want to have it. I mean, again, of course, the American market is somewhat different than the European market. But this is the most important. And then sit together with a dental technician and decide for that specific patient what is the right treatment.
Got it. Markus, one last question, and the last question always belongs to me. Just your clinical feeling. You talked a little bit about zirconia implants also, and then we talked about the brittleness of zirconia. I sometimes have a bad feeling in my stomach having a brittle material in the bone, having a brittle material in the shoulder area where the screw is or the abutment. And then I put another brittle material, like a monolithic material, on top of it. Am I wrong, or is it okay? Or should I? Sometimes I think to myself, oh, maybe I should go for a composite material to make it a little bit more soft. Or is that just a little bit of a gut feeling?
No, I mean, it's certainly not just a gut feeling. It's certainly a concern that we're trying to solve. But again, it really depends on understanding the materials better. And I think we were very much misled in the beginning, like I told you about the veneering and frameworks as well in the beginning, that we thought that a zirconia implant has to look like a titanium implant. Total nonsense. It shouldn't, it cannot. It has a different modulus of elasticity. Even when you just look at how bone reacts to occlusive forces on a zirconia implant is totally different than on a titanium implant. So as long as we're starting to understand this better with those materials, and again, especially the interconnections, as you said as well, we always thought about titanium implant and then made our zirconia implants like that. It cannot be. It cannot work, and it shouldn't work. So, but we're starting to understand it better. And I think there's going to be some great developments happening in the near future.
Give me a quick hint for tomorrow morning. What should I do? Maybe you know what I do today? I sometimes go for one piece zirconia implant and then I cement on top of it.
Again, I think right now there's a bunch of companies that are looking at new interfaces to make it more stable, different types of zirconias as well. Not necessarily, I mean, most of them are stronger, but also, again, like you said, it could be a combination of other zirconias that have a higher degree of flexibility. The thing about, carbon fiber screws, oh my God, I love that stuff, things like that. But we have to think outside the box. And the biggest mistakes that we made is why we saw a bunch of failures was actually when we think titanium and then we just try to imitate that with zirconia. It's not possible. It shouldn't be that way. It cannot be. But if we understand that, I think it can be quite successful.
Markus, that was amazing. I loved it. I love you. I love the talk you did. This was amazing. Also on behalf of the board of the EAO, thank you very much to you. We definitely see you around. You're a big friend of the EAO, as I remember. I don't say too much that we will see you at some point in time affiliated with the EAO. With this, I say good night, good morning, have a great lunch to all around the world. Markus Blatz, say hello to Philadelphia. Is Rocky still standing there in the park?
You better believe it.
Okay, great, wonderful. With this, thanks. Ciao, ciao to everyone all around the world. Ciao, Markus. Thank you very much. Amazing content. Ciao, ciao.